Thank you and good evening, everybody. Thank you, Rosh, for inviting all of us over here in today evening. And Dr. Shan, it was wonderful. So we will be having the discussion what she has already discussed. And let me invite my the panelist, Dr. Shani. We just heard. Dr. Sudeep Gupta, I think he's joining virtually. Has he joined? Yes, I can hear you loud and clear. Yeah, hi, Sudeep Gupta is the Director Medical Oncology at REC, Mumbai. Dr. Vinay Deshmane, the breast surgeon from the Bridge Candy Hospital. He is the Senior Breast Cancer Surgeon. Dr. Boman Dhabar is a Senior Medical Oncologist, my dear colleague. We work together in Jaslok. Dr. Shona Nag, she is the Director Medical Oncology, Sahyadri Hospital in Pune. Shona. Dr. Shalaka Joshi, she is a surgical oncologist from Tata Memorial Hospital. Welcome, Shalaka. And Shaina, why don't you join? Yeah, so we will have the Dr. Shaina Daouz, the another well-known faculty on the breast cancer from Dubai. So here we are going to hear how the patients are managed across the globe. At least we can say the Middle East part of the world. Okay, so I'm going to discuss only one case, and this is actual case of mine, who has been recently diagnosed. She is a 72-year-old postmenopausal woman with no comorbidities, no family history. She presented in fact, her son is a friend of another son of my patient. So he told that my friend's mother is going for the treatment. Then she said that, I also have lump. That discussion in the family made this patient to say that I have a lump from almost more than 3 months. So she had a lump in the left breast, which she noted 3 months back, and it was becoming painful. So then she came to me, and on the examination, it was like locally advanced breast cancer. She had 3 to 4 centimeter skin was involved. There were axillary nodes palpable, and there was left supraocular lymph node was also palpable. So let me ask each of the panelists, and let me start with Tata Memorial Hospital. So how many of your patients now you get early breast cancer? When we were in Tata 30 years back, things were different. Now things might be different. You get more of early breast cancer, or how is the?
So I would say definitely the incidence of early breast cancer is going up even at our center. Today we must be having at least 50 to 60% patients of early breast cancer and 30 to 40% locally advanced. Compared to what I've heard many years ago, it would be exactly the reverse. So increasing number of early breast cancer.
And de novo MBC?
De novo MBC has stayed constant, little higher at our center because of it being a tertiary referral care center. I would say 10% to 15% of all are de novo MBC. Or not de novo, actually, metastatic breast cancer.
De novo, I mean.
De novo must be around 5%, 5 to 10%.
Okay. From your side in Hinduja, Bridge Candy?
About 70% early breast cancers, even 75. But if you look at our population-based data for Mumbai, it's still 50 to 60% are going to be advanced.
Okay. In Pune, Shona?
So similar, it's about 60 to 70% early, and you'll have pockets where there is a mammography available, and when women come in for opportunistic screening or whatever you call it, you tend to pick up these things early. But otherwise, very similar to Mumbai.
Okay, Bowman, anything different?
I think so. Where the patient goes, if the surgeon sees, he may be seeing more of early breast cancers.
Okay.
As a medical oncologist, I see more of advanced diseases. So I would be seeing only 30%, I would say, early breast cancer. 30 to 40 early breast cancers.
No, but the surgeon might be referring early breast cancer to you for chemo, no? Or the surgeons are giving?
I would be seeing 30-40%.
Okay. And let's just hear from the the guest speakers. Yeah, in Israel, how is the thing?
So, look, we have a national screening program that has very high uptake. So the majority of our patients have early breast cancer. And we have, in terms of de novo metastatic disease, we have only 2 to 4% of our cases. And in terms of locally advanced disease, I'd say it's 10 to 15% maximum.
And how many of them are non-palpable, just on screening?
Majority of our patients, most of our patients present screen detected breast cancers.
Screen detected. Oh.
Yeah, we have
So
a very
T1.
high uptake. We've had a national program since the 1990s. All women at the age of 50 are eligible to have screening mammogram once every 2 years. Our National Cancer Society was very aggressive about it, and I was just discussing this with you before. They did note, though, that we had a difference with the Arab population, so they did a very aggressive program, and they take mobile mammogram machines out to the Arab communities, and now we see that we're detecting more breast cancers, but their survival's improving in that community. So even amongst groups where we have disparities, that's also improved with the increase of mammography screening uptake.
Shaina, in Dubai?
I would say it's very similar between all of them. So I would say about 60 to 70% are early.
Okay.
The rest are metastatic, 5% de novo. But unlike Israel, our early breast cancers are mainly palpable lumps. They're not screen detected. And the reason for that is not because we don't have a screening program. The majority of our patients, the majority of the people residing in the UAE are actually expatriates. So the median age of the population is 35. You can't screen these people. So the median age of diagnosis of breast cancer in the UAE is actually between 40 to 45. So you're not actually doing a mammogram in these people. So it's very different.
Sudeep, you want to add something? Do you see the screen-based breast cancers?
No, I have nothing more to add. I think whatever has been said is what it is. I just wish to say that there is no population-based systematic screening in India.
Yes.
And the percentage of patients, if you talk on an India-wide scale, who would be screen detected would be a minuscule number. That's all that I have to say.
Okay. So we did investigate the patient, my patient. So mammography was done. It showed the left breast cancer, left breast, 3 centimeter mass in upper outer quadrant and a little bit on perioral area. There was a periareolar skin thickening. Left axillary lymph nodes were seen. Right breast also showed 0.9 centimeter mass. In BioRad that was 4. And then USG guided core biopsy was done. In the left breast it showed infiltrate duct carcinoma, ERPR negative, HER2 3+, and Ki67 25%, while in the right breast there was no disease. Okay, so that's how the patient was presented to us. Now let me just ask all the panelists that how do you treat such patients? So there was one, this patient, if would have came to me, just because of my other patient, if suppose she would have landed with the surgeon. She had a left suprachoroidal lymph node plus LABC. So Shalaka.
So I'm not sure if she's early breast cancer, if she had a supraclavicular lymph
Yeah,
node.
no, I mean, I'm not saying early breast cancer, yeah.
So she is advanced, and I would like to do a metastatic workup on her in the first.
PET scan I showed, except that there was nothing else.
Okay, so there was an axillary lymph node and a supraclavicular.
Mammography showed axillary nodes.
Yeah, so she had a left LABC, skin involvement, left axillary lymph nodes, left suprachoroidal lymph node, and right also showed in PET scan there was one small lesion. We did biopsy,
Yeah.
there was nothing.
That I noticed. So if she has a supraclavicular lymph node, then she's advanced, locally advanced, and
Yeah.
I would like to give her neoadjuvant chemo. Only fact that deters me is 72 years, but then I would like to make a consultation with the medical oncologist and see what chemotherapy she fit for. I'm sure she may be able to tolerate paclitaxel trastuzumab at least, and maybe that can be given first.
Okay.
Standard practice is
Vinay.
metastatic workup with a PET CT, a medical evaluation, and then basically start off with systemic treatment. Usually they used to start off with a single drug. Now it's become a dual HER2 blockade as fairly routine unless the patient's not affording.
Okay, Shona, Now, they have sent to you.
Okay.
What will you do?
So I would look at the comorbidities.
I said there is nothing, no comorbidity,
Okay.
no diabetes, no
She's a-
hypertension. She's fit.
She's a fit 72.
She is a fit
year.
72-year-old.
So my first choice would be a TCHP-like regimen.
Okay.
I do use it in practice, and I like it. The fact that she'll have to come in every 3 weeks, she won't have the toxicity of a weekly paclitaxel. I would be able to avoid anthracycline, so I'll be very happy with TCHP.
TCHP, dual. Woman?
Medically fit, I would agree with Shona.
Okay. Something different in Israel? Or TCHP, as you said that you like TCHP.
This is maybe the one patient I would maybe still consider giving ACTHP to, just because she's very locally advanced. And on the other hand, these are like one of the only locally advanced groups that we actually cannot usually achieve cure with. And those patients, I like say to myself, is the train on 500 patients enough for me to abandon the anthracycline altogether? But I can tell you that the rest of my team would give TCHP, and I would deliberate.
Shaina? Where, okay, everybody's agreed that you will give the dual. Where will you give only trastuzumab?
If the patient can't afford
If they are
it.
too positive. If they are too positive.
If the patient can't afford it, I would not
Can't
give
afford. Yeah, okay,
pertuzumab.
that's understood. I mean, can't understand.
But this patient has N3 disease. She is a candidate for dual blockade because you're trying to achieve maximal response. You can only do that with chemo plus dual blockade. I would also give neoadjuvant in a 70-year-old. I would avoid anthracyclines. I probably would not give the 3 weekly TCHP because people in my part of the world, they don't tolerate Taxotere at all. They usually end up in the emergency, and if I want to... No, so that's what I'm saying. I wouldn't give the Taxotere. So not 3 weekly, I would do it weekly. But in train, they
So
did
in
do it
TCHP,
weekly. They
you
didn't
mean
do it 3 weekly.
Pacli rather than dosi?
Yes, there is a...
No, I mean, that is your preference, I mean.
No, there is a study, actually, I forget, it starts with P again, I never remember the name. It's a real-life study where
Okay.
they looked at substituting paclitaxel for docetaxel in the TCHP regimen and found it equally effective.
Sudeep, what do you do? TCHP?
Peruse.
So,
What is the hormone?
Yeah, go ahead, Sudeep.
One with me, right?
okay, so I completely agree with Shahina that at least in my practice, patients find it hard to tolerate docetaxel at the recommended dose. And just yesterday, I saw a patient who's received TCHP, but the dose of docetaxel was actually 55 milligrams per meter square, and that of endoxan was 450 milligrams per meter square. One is doing the TCHP, but one is not doing the correct TCHP. So I will tell you what most patients in Tata Memorial Center will end up receiving here, and that is actually ACTH. So it will be clindamycin endoxan followed by paclitaxel and trastuzumab. If an occasional patient of ours who can afford pertuzumab, then I think dual blockade is very much in order in this patient.
Okay, so you are getting a variety of the treatment options available. No one is better than the other. Yes, you can use AC followed by THP, or you can go TCHP. That is, I gave docetaxel, carboplatin, and the Fesgo for this lady. Though there was little problem in the tolerance, but overall somehow she pushed in herself. Weakness, fatigue, nail changes, all those things are common. Loose motions were also there, but she could tolerate it. And I gave her the TCHP, 3 cycles. After that, the PET scan was done. Showed good response, clinically complete response in the nodal as well as the breast disease. We did the PET scan. I will show you the PET scans also. You can see here.
Dr. Sadi, can I just ask you, do you use carboplatin at AUC 5, AUC 6? Do you
I used at 5. This lady was 5.
and do you tap the GFR at some level, and how do you do it?
So-
you give 750 milligrams of carboplatin to people who deserve to get 750, 800.
No, the maximum cap is 900. If you are using AUC 6. If you are using AUC 5, it's 750. We don't go beyond that based on the NCCN guidelines. So I never give anybody, if I want to give 5, especially in 72 year, obviously she received somewhere around 500 milligram, if I remember correctly, because of her creatinine, which was slightly on the higher side. We always take creatinine 0.7 as the lowest. Even if it is 0.4, we consider 0.7 as the lowest as per the criteria, and then we can go ahead. You can see the diagnostic PET scan at the first down. You can see the left supraocular lymph node and the nodes and everywhere. Second is the after 3 courses, and the top one is the after 6 courses. So she just finished. This is on the first week of the Jan. Now the patient is coming to the surgeon's court. Okay, surgeon. Vinay.
Well, I'd place a clip under ultrasound before starting the new adjuvant. If it's responded so well, she has the option of undergoing breast conservation or a mastectomy, depending on whatever she wants.
Even the skin was involved, T4.
I don't think it matters, and we've been doing it for years, and I don't think it really makes any difference to the outcome. And we aren't really seeing, I don't know what others in their practice are saying, but I'm hardly ever seeing local recurrences compared to what we're doing. You do get, when I looked at my own data recently about PCRs, we found a 14% incidence of recurrence after PCR at 3 years.
Okay, anything different in Tata?
No, sir, absolutely right. We would do the same if the response is good, and if the mammography also pre-chemotherapy evaluation and post-chemotherapy evaluation allows us to conserve, and if she's keen, then either a conservation or a mastectomy and auxiliary dissection.
Will you do the neck node dissection?
So if it's completely disappear and it's
yeah,
not
I mean, the scan is in front of you.
Then you can just go ahead with radiation to the neck. You don't have to do neck node dissection.
Okay, you will not do. From the audience, please, anybody wants to ask, please ask, stop me. Anytime you can ask. Let it be healthy. Yeah, Shaina.
Ask a question? I'm just a bit concerned that you said that this patient had a T4D tumor because you said the skin was involved.
No, there are students there. That's why I'm asking that breast conservative surgery is possible even the skin is involved.
So it's not a T4, it's just like maybe an area of the skin, it's not like a T4D tumor.
No, it was not full. It was
every time you have slight skin edema doesn't mean the skin's involved.
Yeah.
But he doesn't have a pathological diagnosis of skin involvement. And one of the things that you really should ask your pathologist if you're doing a breast conservation is that your skin and the subdermal areas are clear.
Yes.
What about the post-operative radiation? Suppose we conserve the
Yeah, so we are coming to that. Even after MRM also she would require radiation. So the treatment I'm going to ask later on. Yeah. No, he is asking about the radiation. If suppose BCS is done.
Yeah,
whether BCS, MRM, she would go for radiation.
No, I'm asking for different perspectives.
Yeah.
Suppose we do MRM, we may avoid giving radiation.
But she's skin involved, nodes positive, the other node.
The base, even the skin is involved, other side we're doing MRM. So what is the better thing, compared to MRM?
So the experts are sitting here. Yes, surgeon.
Well, to do an MRM to avoid radiation, if the patient wants it, yes, you would do it. Would you be able to avoid radiation? I'm not sure. It depends upon your pathological response and really what your radiation therapist actually feels. But someone like this, with having this sort of nodal disease it's very unlikely that you would avoid radiation.
Yeah, but then to conserve the breast in this scenario is a little ridiculous. I just wondering how you conserve the
Because
breast.
conservation versus mastectomy doesn't improve your lifespan.
No, but it will just at least settle down the local recurrence, suppose you
The local recurrence rates are not higher. If you do a proper conservation with this thing, it should not be higher.
Then you have definitely to give the radiation, suppose you conserve.
You have to radiate. If you conserve the breast, you cannot not give radiation.
So this patient is likely to require radiation whether she has a breast conservation or mastectomy because she had such a high nodal burden to begin with and an N3 node. So I don't think this is a matter of avoiding radiation in the first place, the choice of surgery. I would discuss that more, in patients who are early breast cancer, T1, T2, N0, where a mastectomy would mean not taking radiation. That's a different scenario. Here you are anyway going to get radiation. I totally agree that there is no level 1 evidence in locally advanced breast cancer to really do breast conservation, but it's really 15, 20 years of practice has probably told us that it is safe, and we have a lot of retrospective, prospective data already published on this, that it may be okay to go ahead with breast conservation surgery. And good responders, definitely. If she were not to respond so well, and if she were to persist to have the PDO and the nipple thickening or areola thickening or lymphadenopathy, then definitely she would need a mastectomy. But in good responders where everything has disappeared, we would do a mammography, and if there also everything is looking like good response, then conservation should be safe.
Yes, Boman.
There is some data, you can correct me, that by using pertuzumab, in fact, the local recurrence rates have been low.
So
by adding pertuzumab to transfusion.
So let me ask Dr. Shani.
I think the local recurrence rates would really be low if you've done a good breast conservation and you're given really good radiation.
From the medical oncologist point of view.
Yeah.
Okay. So what percentage of such patients will you expect the PAT-CR?
Around 75% on average.
Okay.
Majority of patients.
The trend trial you showed 68 around percent. So somewhere around that. Shaina?
So if you look at the train trial, the overall PCR rate was close to 70%. But in those patients who had an ERPR negative, HER2 positive, which is what she has,
Yeah.
it's actually much higher than that. But taking into consideration her burden of disease, maybe it's not close to 90%. Probably it's what Shani said. Probably anywhere between 75 to 80%.
Woman? With high disease burden like this, 75-80%. You agree?
Neosphere showed about 50%.
No, but in Neosphere, they gave only half the chemo pre-op and the rest of the chemo post-op. But in Train, they gave all the chemotherapy.
Here, this is
Here,
only after 3
TCHP
cycles.
all 6.
All 6 finished.
All
You said
6
only
finished.
3, I thought.
No, all 6 finished. 3, I showed you two scans. Sudeep, what do you
60%.
feel?
60%. 60%.
Well, from whatever I know and from whatever I've experienced and from whatever data is published, I don't think there will be a PCR of 75 to 80%. It's just too optimistic. It is not nowhere near that number. It is usually of the order of about 50 to 60%. But in one of Shahina's conferences, I saw data that baseline stage and the extent of disease prior to neoadjuvant also impacts on the possibility of PCR. So in this woman who has node positive disease and locally advanced breast cancer in N3, I think it will be about 35 to 40%, maybe 35%, somewhere thereabouts. But maybe, I don't know, 75 to 80% is too high. Unless you are giving neoadjuvant chemotherapy to people with T1 and 0 disease.
I do agree, Sudeep. I also feel that, I always see that we have reached a plateau of around 60-65%, irrespective of the HER2 or in triple negative, if you see with the addition of the Pembro, it's 62. If you see here TCHP train is around 64. So I think probably we have reached the plateau there. We can't go like earlier TNBC where chemo only 40%, now 40 to 64 with addition of Pembro. So maybe something we may have to add to go up further. At present, 60-65%. China, hope that we will see that day, 75 to 80%. Okay, so everybody feels that PAT-CR probably will be achieved in this lady, and then what after that? Dr. Shani.
No, but we can't say that PAT-CR may be achieved. I think the odds are less than even that she will achieve a PAT-CR with the kind of disease that she had.
Yeah, we are hoping. Shaina said that 75 to 80% chance. So let's hope that we will see that.
I'm actually listening to all of this, and I looked at my data, and I've seen even I have a whole bunch of IBC patients. I'm talking about the ERPR negative, HER2 positive, and I have patients locally advanced, and we do have high PCR rates. So the biology of disease also matters. ERPR positive, HER2 negative, they have lower PCR rates. ERPR negative, HER2 positive, they have higher PCR rates. Now, if this patient achieves a PCR, 100%, in my humble opinion, she needs to continue with dual blockade in the adjuvant setting. together with radiation, her nodal burden was very, very high, and you keep mentioning that she had skin involvement as well. So I'm a bit concerned about that breast conservation surgery still. I'm going to keep harping on that. But that's where MDTs come in, right, in terms of discussing cases to get the optimal therapeutic management for patients.
So then, China, how do you decide about the skin involvement? Let's discuss about the skin, No? Okay. So, those patients who achieve PAT-CR, they do well. Slides, please. You can see from these data that, pooled analysis that those patients who achieve PAT-CR probably will do much better. But still, there are some patients of the PAT-CR also progress very rapidly. I mean, those are there. Everybody sees in their own practice. Shona is nodding. You see that? Yes. Okay. How fast?
It's not fast, but I think PAT-CR doesn't mean there's going to be no recurrence. We shouldn't be falsely influenced like that. And about 10 to 15% of patients who achieve a PAT-CR are known to relapse. So we've got to keep that in mind.
Okay. We know that all the guidelines have recommended to use dual blockade. But if suppose, Sudeep, this lady cannot afford the pertuzumab, only trastuzumab, if suppose she would have been. So would you have gone for a short course of trastuzumab or full 1 year pertuzumab?
This woman would require 1 year of trastuzumab. That is very much in order. And like I said, most such patients will receive ACTH followed by trastuzumab to complete the full 1 year. That is what we would do in most of our patients.
Okay, that's practical. That's why I asked, because pertuzumab we are talking, but that is not practically possible for everybody. So you can use trastuzumab. Now it has become cheaper, and many patients can afford trastuzumab. Continue at least for 1 year. Don't look for short. Are you in favor, Dr. Shani, for any short anti-HER2 therapy or 1 year?
The only patients that do shorter anti-HER2 therapy is if I have a patient with very low risk disease or a patient who has got relatively low risk disease and has got cardiac problems or other major medical issues which are probably going to be more life-threatening for them than their breast cancer. But otherwise, I'm very careful about, I would avoid it if there's not a good reason.
Okay. Shaina, you use anytime short HER type protocol?
When my patient cannot afford it.
Okay, only finances decide. Woman, in your practice?
True, majority of the time it's when the patient...
No, now you can send the patients to India now. They are cheaper now, or they can buy from here.
I do agree.
You do agree, send patient to here.
Most of the time it's 1 year. Yeah, that I agree, but I say that most of the time it's 1 year.
Shona is laughing. She is saying that send to Pune, not Mumbai. Okay, so, obviously, let me ask the surgeon Vinay, which HER2 positive patient will you send to us first, the medical oncologist? Same as what she had shown, 2 centimeter less than that, or do you have some other criteria?
Well, today in my practice, most of the HER2 positive, I will actually ask them to meet the medical oncologist. Okay. Even if I want to operate first, I will actually ask them to meet, simply because these are the standards and they have to know about it. There are 2 groups but which I have doubts about. One is, we know that whenever there's slightly advanced disease, I don't mean when there's edema and a locally advanced disease of that type, but let's say you have a 3 centimeter tumor. Now very often here we do say that in our thing we must give neoadjuvant chemotherapy with HER2 positive. What if the patient really wants a mastectomy? Is borderline affordability? I'm not really very sure as to how much is the overall survival benefit if you actually do a mastectomy on these patients who want a mastectomy. I'm not saying you convert them to a mastectomy although they don't want one. And then you give adjuvant, the regular chemo plus trastuzumab versus what you're going to do with this, and especially if they're node negative.
So you can answer that. He's saying adjuvant rather than neoadjuvant. What percentage of benefit is there with neoadjuvant?
I'm saying for a group of patients who are not really advanced, like with node positive disease, like edema of the breast, but they just have a T2 tumor, which is early T2. T2 can be up to 5 centimeters, but we're talking about 2.5 to 3 centimeter tumor, which you would normally consider for a HER2 neoadjuvant treatment in today's era. But this patient specifically just says, I don't want to preserve the breast. I want a quick mastectomy. And is on borderline affordability. He's not going to get pertuzumab and trastuzumab really on a platter. He's going to pay for it. Then how much is the benefit by giving adjuvant chemotherapy as trastuzumab versus giving pertuzumab and all this treatment with neoadjuvant treatment and adjuvant treatment going to really make a difference in survival? And I think that's a very important question that we need to answer in the clinic.
So I'll start by saying that we also, all our patients who are HER2 positive and triple negative will see an oncologist before any final decision's made. Everyone's discussed in our MDT meeting. It's true, look, there's T2 and there's T2. And so there's obviously a group of patients who will benefit from starting with surgery because then they can maybe just get Taxol Herceptin. However, my concern is, what if this is a patient who has more extensive disease, it's a 3 centimetre tumour, maybe she does have a node involved, and if she were to have a tumour that didn't fully respond to neoadjuvant therapy, this is a patient who would be missing out on the benefit of TDM1. So what I do with these patients, who I think are borderline, whether they need surgery, like they're over 2 centimetres, around 3 centimetres, I sometimes give them THP. Without the carbo, I give them like 12 weeks of Taxol Herceptin Perjeta, and then if they really had like just a 2.5 centimetre tumour, it usually disappears. And if they have residual disease, I know that they're going to get the TDM1 and they haven't missed out on what I think is quite important for their survival benefit. Happy to hear.
Shaina, you might be also getting patients. Suppose they from India, you have expatriates lot. They have come to India to visit home, but they got the breast cancer. Now she said, no, I don't want to do surgery there. Finish surgery here, HER2 positive, then I will take the adjuvant therapy. Is there something wrong there, or it's okay?
I'm very dogmatic, I have to admit, when patients have HER2 positive disease. For me, if the patient has, a 2.5 or 3 centimeter tumor, you're going to give chemotherapy in the adjuvant or neoadjuvant setting. You've already stated that. I'd prefer for it to be given in the neoadjuvant setting. It gives you, a sense of the sensitivity of the tumor to the chemotherapy. You are able to determine if the patient achieves a pathological complete response or not. And then post-op, like Shani said, if they have residual disease, that patient has ability then to get TDM1. But of course, affording it is difficult. But that's where Roche comes in. And,
They don't give free.
So, no, even in Dubai, it's not free. But if someone cannot afford it, there are programs that they can get on. And maybe that's something you do need to discuss with the companies to bring that into play. And sometimes I have seen also patients say they can't afford anything. But the minute you give them chemotherapy and then they go for surgery and there's residual disease and you tell them their risk of recurrence is higher if they don't take TDM1, somehow or the other, they get to take TDM1. So at least you give them that opportunity to make that decision. I don't think we should be making that decision for them. I think biology should make that decision for them.
I need to be fair and just say that I have a lot of degrees of freedom because we have a universal healthcare system.
Yeah.
And our patients have accessibility to almost all, not all, but almost all the standard of cares they need in the early setting and largely in the metastatic setting. So I guess I should just qualify that I can say these things, but my patients don't have the same limitations your patients have. And I guess it changes the whole approach and all the considerations.
No, I agree. Finance makes a huge issue, and we face it. I mean, we've discussed this so many times. We face it in Dubai as well. But if the patient is going to have chemo plus trastuzumab anyway, why not give it to them in the neoadjuvant setting and then see what happens in the post-op setting?
No, logistic issues. There are sometimes logistic issues. Patients say that no, there are some problems, some family function.
That's a different issue altogether. If there are logistic issues and the patient says no, I just simply don't care, I want to have surgery up front.
I think the question really that we need to answer is, of course, if you want to give it neoadjuvant, you're going to give this, that's fine. In ideal situations, you know what you're going to do. This is not an ideal situation. This is something which we face day in and day out.
Yeah.
And the question that really needs to be answered is not that we are going to give TDM1 or this. I think the question is, how much am I compromising the survival of that patient? And that figure is something that my patient may want to know. She'll ask me, doctor, if I don't do this, how am I compromising my survival? What is the figure that one can quote?
7%.
You can tell her that if she's in the 20% that wouldn't have had a pathological complete response, because we can assume that she might be in the 80% that would, because it's a 3 centimetre node involvement. If she's in that 20% who doesn't have a complete response, then she's compromising her outcome because she won't get the TDM1. You won't know to give her the TDM1. That will impact her survival.
We're not thinking of TDM1 because of the
costs.
affordability. So the question is we
Okay,
She's not,
let-
she's not getting TDM1.
She can't
If,
get
if
it.
you don't have post-neoadjuvant therapy, then I don't think it makes a difference.
That's,
But she needs
that's
to
the
know
important
that-
answer. Yeah.
Yeah, she needs to know. But if there's post-neoadjuvant therapy available, then she's potentially compromising her outcome.
I think let's move. We have only 1 minute. Sudeep, let me ask last question regarding the same thing, that your patient has come, say, from Agartala, and now she had come here. She cannot afford trastuzumab, she cannot afford Perjeta, she cannot afford the Kadcyla, and now she has got a T2 lesion. Now all the way she had come from there. Now she doesn't want to go and come back again. Will you advise to go ahead surgery? In any case, if she is not going to receive the Kadcyla, what is the harm in giving? Your survival rate is going to be the same, early or afterwards. You agree, Shalaka? Yeah, Shalaka is agreeing.
Yeah, so I think in the specific situation that you pointed out, if TDM1 is not feasible at all, and if breast conservation is not an issue also at all, then of course, surgery can be performed first followed by adjuvant.
No, there are young people in the crowd, so I thought it's.
All those conditions are fulfilled. You see, as Shahina correctly pointed out, anyways you have to give the chemotherapy either before or after surgery.
Yes.
And sometimes these decisions on whether one will be able to take TDM1 or not, whether one wants a breast conservation or not, are not made in a day or in half a day. So what the neoadjuvant chemotherapy in a 3 or 4 centimeter tumor will allow is to allow the patient 12 weeks or 16 weeks of contemplation on what might happen post-operatively. So I think, in this situation, most people all over the world will end up giving neoadjuvant treatment. But of course, it is not wrong to do surgery adjuvant treatment if TDM1 was completely off the table and if breast conservation is absolutely not doable.
Yes, Bowman, you want to add?
Before trastuzumab Purdue also you are practicing.
Yeah.
So what were we doing at that time? Do the same thing.
Same thing. Okay, Shalaka, last comment. Then we will move to the.
No, sir, I completely agree with that, what Dr. Gupta has, I think, already summarized. But what I wanted to say is this, if she were to be node positive, then there is something coming up about conserving the axilla post-chemotherapy that you may not be able to do upfront in a HER2-positive patient. So that's the only case where today I think that maybe neoadjuvant chemotherapy, although I don't think we have enough data, level 1 to really recommend it, but I may consider giving chemo first to be able to later, 10 years later, conserve the axilla. Maybe we'll have some more
surgeon's perspective. Okay, so let's go to the last. Our time is already
Dr.
up.
Bashade, if you permit me to
Yes,
ask
please.
one question. When we wouldn't give the chemotherapy to HER positive patient, even a T1 and 0, PET scan negative all around?
0.5 centimeter, less than that. Do you agree, panel? If the tumor is less than 0.5 centimeter, it is less than T1, A. That means that, we have to be in Israel, all screening best.
Is it evidence? No. I'm just, any evidence is there? That if it's more than 0.5, it's between 0.5 to 1 centimeter.
There is evidence. There is evidence. That's why the 0.5 figure has come in. So let's ask Dr. Shani in Israel what they do, because they are getting such small tumors.
We have T1B HER2 positive tumours,
Yeah.
and we give them Taxol Herceptin. I can say, maybe I'm not allowed to say because it's a Roche event, but I'll say it because no one's told me I'm not allowed to. I have had elderly women who want treatment, do not want to have hair loss, and they've had insurance, and I've given them TDM1. So that's off-label use. But the T1Bs, most of them will get treatment in Israel. and we see quite a few.
And any difference if the tumor is in a premenopausal woman and a postmenopausal woman?
If it's a premenopausal woman, then we don't really deliberate. If it's an 80-year-old woman, I'll discuss it with her. But most of our patients, most T1Bs will get treatment also if they're in their 60s in our centres.
Woman, how many of your patients you give Fesgo? Are you comfortable? Is your staff comfortable giving Fesgo?
Yeah, at least in whom I have converted from IV to subcutaneous, they have not gone back to IV preparation. That much I can tell you. So at least it looks like they are satisfied. But to convince them, with the port and IV, as you rightly said, the barriers are still there. To convince them.
Are you convinced the long-term data about you have the long-term data of Cleopatra or anyone adjuvant affinity, everything?
Fesgo, obviously, we do not have the data, but we believe that it is the same
You
thing.
believe?
So we believe that it is the same thing.
So
And
you prescribe. Shona?
Can I ask?
I'm coming to you,
No,
Shaina.
but this is just a very practical question that I wanted to ask you.
Okay.
Fesgo price and trastuzumab price, is it the same?
Here in India?
Yeah.
I hope so. As 75-80% PET-CR
I'm
price
talking
also
about-
should be the same.
No, I'm talking about trastuzumab versus Fesgo, which is both trastuzumab and pertuzumab.
Shaina, it is, the cost is different by a factor of about 5 or 6.
Okay, so then again, cost is going to be an issue in terms of using
so
it.
it's
right?
cheaper than IV trastuzumab, pertuzumab.
It's still more expensive than trastuzumab.
Much more. Like Sudeep said 5 times, because we have so many brands of our own trastuzumab now. So I've switched to, in those that take dual anti-HER2, I've switched to Fesco completely.
Yeah.
And the biggest advantage has been I think all of us have women going on pertuzumab, trastuzumab for many years in the metastatic setting, and this has been absolutely fantastic for them. And there are some of them who live very close to the hospital where the trained nurse goes and gives it to them in the home. So they don't feel like patients at all, like Shani said.
So, Dr. Shani, you.
Put things in perspective, sorry, Dr.
Yeah.
Just to put things in perspective, Shanika, so the cost of 440 milligrams of generic trastuzumab is about $140 or $130, and that of Fesgo will be about $1,300, about $1,300. That's how it is.
No, Shaina is saying and Roche is listening. So don't worry, it will become one day that price. Yes, Shalaka.
I have a question rather. If I'm a little worried if we don't see many patients on pertuzumab, trastuzumab, neoadjuvant combination, but maybe now Dr. Gupta and others are giving a few patients who are affording. So if there is, I'm a little worried if there isn't a PCR. Are we okay to then switch over to TDM1? Do we have like enough data? Because I think the data for TDM1 comes from a study which talks about if there isn't a response after trastuzumab. So after trastuzumab and pertuzumab, if there isn't a response, I'm a lot more worried then. Would you?
There were patients in the Catherine trial
16%,
that did receive dual blockade.
And Shalaka, I think those that don't get a PAT-CR with Traspert are the truly resistant ones that will then benefit from a change in strategy.
So I had one patient from the toxicity point of view that she was on IV trastuzumab and pertuzumab. Loose motions were under control. I mean, she used to get 1 or 2 loose motions, but when she went in Fesgo, she started getting 10 to 12 loose motions per day. So, in one patient only, we investigated everything. We never thought it was because of the Fesgo. So, we investigated everything, didn't turn out to be anything. We went back to the IV form, only one patient went back, but persisted. Loose motions persisted. Was that something Fesgo effect? You see loose motions quite common?
I see loose motions common with the incorporation of pertuzumab.
Yeah.
Period. When the patients keep going on the Fesgo afterwards, I have very few patients that continue to have loose motions, but there are some, but usually very manageable. The problem is a combination of the pertuzumab and a taxane.
Okay. So we have overshot our time from the audience. Anybody wants to ask any question? If not, then I thank my panelists, thank Rosh, and thank the Sudeep and Shona organizers for having all of us over here. Thank you. Thank you very much.